This video abstract discusses the paper Waveforms Analysis in Patients with Amyotrophic Lateral Sclerosis for Enhanced Efficacy of Mechanically Assisted Coughing. This is from the October issue of the journal by Sancho and colleagues. Cough augmentation with mechanical insufflation-exsufflation has become standard therapy for treating ineffective cough effort in ALS, but upper airway collapse during therapy as a result of bulbar dysfunction can decrease the effectiveness of MIE. And this can occur during both insufflation and exsufflation, and increasing the pressure can lead to a greater degree of obstruction. Transnasal fiber optic laryngoscopy has been used to evaluate upper airway response during therapy and has been successful in some cases for optimizing settings to eliminate laryngeal collapse. But it is an invasive procedure and it may not be readily available. The aim of this study was to evaluate waveforms generated during MIE therapy to detect airway obstruction and to modify settings for effective mechanically assisted coughing. This was a prospective cohort study of individuals with ALS hospitalized during a 2-year period from 2018 to 2020. MIE was administered with an oronasal mask using 4 different sets of insufflation-exsufflation pressures, including plus or minus 20, 30, 40, and 50 centimeters of water pressure for 6 to 8 cycles with an inhale time of 2 seconds, exhale time of 3 seconds, pause time of 1 second, and using the automatic mode. Pressure, flow, and volume were measured during therapy with a linear pneumotachograph, and a pressure transducer was placed in line between the mask and the MIE circuit. The primary endpoint was to determine if the waveforms could be used to modify therapy settings for an effective treatment, and the secondary endpoints were to analyze the different patterns identified in the graphics and relate them to clinical variables. 69 subjects completed the study and all had some degree of bulbar dysfunction. Over half had upper motor neuron involvement and used an MIE device at home. Over 50% of subjects were found to have obstruction during insufflation, and that was associated with upper motor neuron dysfunction, whereas 26% experienced upper airway collapse during exsufflation, and that was related to lower motor neuron dysfunction. This figure shows the optimal flow time and pressure time graph. On the top section you have flow, so here's insufflation followed by exsufflation and pause time, and on the bottom for pressure, here you have insufflation, exsufflation, and pause. When obstruction during insufflation occurred, you see this spike at the beginning of insufflation, and you can see this in both the flow and the pressure time graph. When collapse occurred during exsufflation, there was an abrupt flow decrease after the cough peak flow at the beginning of exsufflation, and you can see this flattening of the curve. After utilizing the waveforms to optimize therapy settings, the mean insufflation pressure was 34 centimeters of water pressure, exsufflation pressure was 39, the insufflation time was 1.65 seconds, and the exsufflation time 2.9 seconds. All subjects except for one were able to achieve optimized therapy settings for MIE after waveform analysis. The effectiveness of MIE in patients with ALS is dependent upon the severity of bulbar dysfunction, and high insufflation pressures have been associated with upper airway collapse. This obstruction during insufflation can prevent lung inflation prior to exsufflation. Cough peak flow is not a reliable indicator of upper airway collapse, as it has shown to increase despite the occurrence of airway collapse. The authors found that upper motor neuron dysfunction was related to obstruction during insufflation, while lower motor neuron dysfunction was associated with collapse during exsufflation. Some of the study limitations were that there was not any imaging of the upper airway to compare with the graphics obtained during MIE, and this is needed to confirm the correlation of the results with anatomical changes during MIE therapy. Additionally, subjects were asked to remain passive during therapy sessions without any type of cough effort. The accompanying editorial by Anderson and Bolsetter discussed the importance of evaluating the entire cough cycle and not just the cough peak flow, given the limitations of using cough peak flow alone as an outcome measure, since it may provide a false reading of MIE effectiveness. The authors conclude that customized settings seem to promote an optimized response to MIE therapy. In conclusion, waveform analysis is a non-invasive method that can be used to evaluate upper airway response during MIE therapy, and the authors identified two phenotypes of obstruction for subjects with ALS. Thank you for your time. Be sure and follow the journal on any of our social media sites for updates and new content.